one of the comments about how do we make sure that we don't end up creating silos. If I say nothing else, or if you hear nothing else I say, I think we are at a pivotal time where the solidarity of our efforts have to come together to move the needle around addressing health equity. As we all know, many of us, when we think about the work that we do, we see these inequities play out in so many different ways. And so I'm excited because this is the only panel with an attorney, a healthcare provider, specifically a mental health care provider, a community representative representing the patient voice, and a patient advocacy group. So this is the best group in the house all day. I'm just saying, I'm just saying. So as we begin, what I want to ask our panelists to do is, in their introduction of themselves, to also describe how they've seen systemic and structural issues present in their specific areas of expertise, and why today's discussion continues to be critically important. I'll start with you, Tamika.
For inviting me to be a part of this conversation. I am Tamika English, and I am with Sister Love Incorporated. We are one of, or the oldest, reproductive justice organization in the Southeast. I am under the leadership of the dynamic Dazon Dixon Jallo, and I am here today to represent the voice of the community. So, looking at our current structure and talking about how it shows up, Um, for us, being in the position that we are as a community based organization, we see ourselves, if you will, as um, an intermediary. They come to us first before they go to the clinical settings. And a lot of times there is hesitancy there, there's mistrust there. And here we are in this prime position in the community where they are, a place where they come to in the wake of that mistrust or hesitation. And so our roles are very, very critical because what we say in that appointment makes the difference between them following up with their healthcare providers. And what we see often is we do the work, we set them up with the appointment, and when we follow up, the experience isn't the same once they get to the provider, where there's someone there that will walk them through the process, that cares about whether or not they're capable of filling out all the paperwork in the same fashion that we were. And so then there's the disconnect. And we find ourselves having to start all back over again. So having that community based approach uh, throughout the healthcare model would definitely give us much greater outcomes than when they leave us and then they go into this huge system where they become just a number.
Good afternoon. I'm Dr. Ravi Kolli. I'm a psychiatrist in practice for past 30 years in Pittsburgh. And I want to thank Pfizer Multicultural Health Equity Collective and Morehouse, as well as the Century Foundation and Nacho, nice name, and the Minority Equality Forum for organizing this very important, critical conversation for all of us to participate. And I'm a psychiatrist, like I mentioned, so I do see the intersection of all these problems affecting my patient care, my patient care's outcomes. And I'm also president of an organization called AAPI, American Association of Physicians of Indian Origin. So we are a strong group of physicians. We represent about 120,000 physicians that live in this country from my motherland and second generation of physicians. So that's about more than 10 to 12% of the total practicing physicians. So we are a strong ethnic group of physicians organization. We do a lot of advocacy and charity and a lot of social networking and political kind of activities as well as continuing medical education. So this is my term I'm doing right now. So I represent those values, and we were very fortunate to be able to benefit from the system in both countries, but there is so much room to improve. And sometimes, for example, I'm in a medical advisory board in Washington County, in mental health advisory board, and I'm the only token minority there, and I should not be that person. And there should be more than that. And so I want to make sure that I brought that up, that issue, that why are there no more minority participation here? And it seemed like I took that spot, but I don't think that should be the case. But I was advocating for inclusion, and without inclusion, there's not going to be any equity, obviously. And so my thought is equity equals quality. I mean, without equity, there's not going to be any quality, right? And equity equals ethics. Equity is an ethical decision. We have to all participate and impact. So we need to combine a term that combines quality and ethics. That is equity. So that is actually the word. Probably we should redefine it as an ethical quality care. That is what equity is, in my opinion. So the fairness, the opportunities have to show up in outcomes and improved lives and improved livelihoods and improved economies, improved societies, communities, and and collectively we all have to be there. Otherwise, it's not happening. Otherwise it's not right. We have to make it happen. And the fact that it's equity in action, that's what we are here for, to learn how to proceed from just thoughts and ideas and discussion to how to make it happen. So that's why I'm here to kind of understand from you, from your questions, how we can improve our conversation and make it happen.
Hi, I'm John Daniels, notoriously identified as an attorney, but I just say I'm a choir boy from Milwaukee who came down here to spend some time and learn from all of you. My experience is very similar to the underlying notions that have been described relative to what does it take to change a system fundamentally to make access more possible for those people who don't have a voice in the room. So for the last 20 years or so, I've been on the board of directors of a number of large health systems. Initially, I have to admit, it was because of clients who said, John, we'd like to have you on the board. It won't take much time, and the CEO, et cetera, et cetera. But I don't think they realize that when I go on a board, I really want to know what's going on, particularly around healthcare, because all of us have lived experiences around healthcare, our families, our friends. So you bring that experience with you in the room. So now one of the things that I'm involved in is Black Directors Health Equity Agenda, which is 400 African American directors and senior executives in health systems of all the big systems across the country. And we recently had a meeting here in Atlanta a couple of weeks ago. And one of the underlying things that came out of that was that the issues in Pittsburgh or LA or Mississippi or Milwaukee or Chicago, that there's some underlying themes. And one of the things that I think around the issue of access and equity, as you were mentioning, both of you were mentioning, is how do you come to the party to have a dialogue where you're dialoguing as equals, as opposed to I'm here from the big health system, and I'm going to communicate to you the things that we know are important. And by the way, we'd like some of your input so we can, put that in the report that we have to file with the government. So I only want to say thanks, Pfizer, for doing this, because our group of 400 got started 8 or 9 years ago in New York with 12 of us. And Pfizer was so kind to bring that group together. There had never been a group of African American directors of big health systems who coalesced. In fact, there was no list of who all these people were. And Pfizer has been an incredible partner. Their CEO was our chair last year of our national event. Melissa's been great. I can't say enough about that. But changing the dynamic in healthcare is going to be really difficult because there's so many entrenched interests. that even when you know the right result, you still have to navigate around those issues.
Absolutely. So some things that jumped out to me were change, be intentional. It's not just about an invitation, but it's about allowing that person to have equal influence in the decision making process. So as we think about healthcare facilities and think about healthcare delivery, if we're not making those changes that are creating space for those diverse individuals, uh, plural S, that means more than one, creating space for those diverse individuals to not just have a seat at a table, but also really have a very intentional position in the decision making process. And it doesn't happen once, it has to happen continuously. And the reality is, guess what? Change takes some time, but we have to be intentional. So, for our healthcare facilities and healthcare delivery, intentionality, deliberation, continuity, consistency, and space. Y'all got all that out of that? I'm a social worker, I'm a therapist, so I'm supposed to listen and give it back. I know it's after lunch. Don't y'all start. I was married to a preacher for 25 years. I'll pass a collection plate if y'all get quiet in here. We said our community based organizations need resources. They are all in this room. All right? So get quiet if you want to. So one of the things I think is critical, and we heard this on one of the panels earlier, was really this concept of trauma informed care, because we have lost an appreciation for the intellectual experience of individuals. So, Tamika, can you talk a little bit about that in the context of a patient and why that understanding is so critically important for our healthcare facilities in healthcare delivery?
So we have a way of approaching people when they come to us. Say, hey, when you go in to see your healthcare provider, no matter who it is, there's two experts in the room. You have the doctor or the practitioner who has gone to school and has an education and a degree and a certain level of knowledge about the body. But you are the other expert because there's not one other person in that room that understands your experience and your body the way that you do. Your level of expertise in your body is comparable to all the years of schooling that that doctor has had. So make no mistake about it. There are two experts in that room when you go and you sit down with your healthcare provider. So that's one of the ways. And then when you approach from a trauma informed framework or lens, if you will, the question isn't what's wrong with you, what has happened to you. The question is, what can I do for you? Where can I meet you to start you on the path of being better? And sometimes it's going to change. And we just had this conversation in the other room. It's not going to look the same for everyone. So the model requires that you are ready to pivot at any moment and make adjustments to meet them where they are, no matter where that is, because that's the only way we're ever going to have equitable care. Each individual will require a personalized plan and a level of attention where there are some systematic processes we can put in place that will keep things going and efficient and easy. But literally every person that we come across, we have to take the time to get the information, to have the conversation, and to set them up on a plan of care that is specific to them and based on where they are.
Yeah, now I'm going to wear my psychiatrist hat here, not just a physician leader. And what she said is exactly right. The person-centered care, meeting them at where they are and making them be the expert in managing the care is the key. That's what we do. I also do assertive community treatment. I go to their homes with my nurse or with my therapist and talk to them at where they live, where they breathe and eat and everything. So that gives you a totally different perspective than when they come to your office, and that's different. So they feel more engaged, they feel more connected with you, and that's a really a learning experience for me. So I'm learning from their expertise of how they manage their care. And trauma, of course, there's so much trauma, and especially in the mental health patients, that is causing their continuous suffering. And any treatment modality that kind of doesn't take into consideration and re-traumatizes by our approach can be very damaging. So we need to be very careful and very gentle at the same time, not be very kind of let it go. And they need to kind of empower them. They need to make them. We need to make them believe in themselves and give them that hope and confidence that they can do it. They can do it. So we need to kind of guide them, manage their difficulties on their own, with us being there, listening to them, just gentle listening, active listening is very important. When we listen, we learn more than when we talk, right? So listening is so important, and that's how I approach for an individual patient. But I think the same approach has to be happening at the institutional levels. We need to engage them at where they are and make them feel they are the experts in solving the problems. We're there to help them, to provide the resource and connect them. And
Yeah, I want to sort of follow on what the two of you talked about from a governance standpoint. And here's how I sort of captured in my own mind. So I have a physician who's treated me for a whole bunch of years. He also happens to be a personal friend. So the treatment I receive, you know, I'm very, very happy with it. So my theory is that everybody should have that same kind of treatment. They should have those same kind of relationships. And we don't have that. And until we put the spotlight on changing sort of that dynamic, which takes courage, because there are a lot of elements why people don't want to change that dynamic. There are also financial elements that impede that. So I think if we can get all of those people who are involved in the system to have a lens that, hey, the way the people in this room are treated is the way everybody should be treated. And I think one of the challenges with that is that if you don't have the lived experiences of other people, it's very difficult to sort of have the kind of empathy and understanding, which tells me you got to have people in the room who are willing to make the effective challenge. And frequently, that's not a comfortable role, especially as you were mentioning, if it's one or two, it's very uncomfortable. But you know, you got to get comfortable that that's why you're there. You're there because somebody else helped you get there, and you're there for the people who need the help and whose lives are affected every day. So I think from a governance standpoint, we just got to be a lot more rigorous in saying, hey, this model has got to be more reflective of the people who are being treated.
So, so one of the things I think that's very important in what I heard you say is, we're talking about governance, right? So we're talking about healthcare systems and very regulated, regimented environment. However, what I also heard you say is there are opportunities within these structures that need to be augmented. And I would even go as far, based upon our prep conversation, that some of these structures need to be dismantled. So, John, could you talk a little bit about the role of governance in making sure that equity truly becomes the fabric of a healthcare system, and it is not a checkbox for reaccreditation? It is not just an exercise in fertility, but it actually becomes transformative and not transactional.
Yeah, I appreciate your asking because I think it's really critical because everybody sort of knows how to give the narrative around inclusion. I mean, you don't find a healthcare provider that's not smart enough to say the right words. It's really a function of, okay, how do you make that a central part of the way healthcare is delivered in your business? And just like safety 25 years ago, took on a different context. From a governance standpoint, we have got to put much more focus on these issues that we're talking about today. And like everything else, people are going to be a little uncomfortable initially. But the other part of it that both of my fellow panelists were describing is that this helps healthcare for everybody. It's not just sort of the minorities who get the. When you do better models, it helps everyone. And so my view of it is in terms of governance is very, very important. One of the things that we've done, and I'll stop, is we created a playbook for a board of directors around the country about actionable things that they can go into the boardroom and say, well, at Grady, for example, I see my colleague from Grady here, here's what they did that was more effective in terms of, a particular need. And as the more of these examples you share nationally, and people don't think of it as just my problem in, Toledo, the more you can move the needle forward.
What you talked about was you made the comment. Well, first of all, I'm going to go to a comment that I heard earlier this morning, which was to not address social determinants of health should be considered malpractice. Did somebody tweet that? Because that's like, you still got time. And I raise that because I think that that would probably align with your thoughts around not addressing mental health. And you were very explicit to say in our prep that we are only going to be able to move so far in addressing health equity if we don't address mental health equity. Can you speak to that?
Absolutely. And to paraphrase past presidential candidate, women's rights are human rights, right? So our patients' rights are human rights. Equity is a human right. So we cannot skirt that. So we need to make it just a human right issue. And consequently, the legal system has to accept that too, and we have to force it sometimes. And I lost my chain of thought a little bit. So you talked about transformative leadership versus transactional. I think the center to periphery kind of leadership, ripple effect kind of leadership is very important in kind of changing the minds, changing value systems, changing the kind of behaviors. The top down doesn't work. That's transactional relationship, transactional business type of interactions won't work. You can command and control leadership doesn't work. The coalition building and the center to periphery type of leaderships will work and transform the care, transform our society. So sometimes you have to fight, sometimes you have to work together. So we need to figure out where we need to fight and where we need to come together to find common goals and make everybody winner. No, you can't. If there's an argument, nobody's going to win. It will continue forever. So we need to make sure everybody wins something, or everybody gets something out of this conversation, and eventually it can work well for everybody. So we need to make sure that that happens in our conversations. And even the rural health equity issues need to be brought up, right? So it's not just urban health equity issues, and even rural health equities. And then my favorite topic is mental health equity. Without mental health equity, there's no equity at all. Unless we integrate mental health into the regular system of care, we have so much fragmentation, and we are just throwing resources out like that without any real outcome because of fragmentation, because mental health being or substance abuse not being prominently treated or equated to physical health. So that's very important. So we integrate all these systems and these harm reduction practices. All these things have to be there for us to succeed. And we're not going to get there in one step. So we need to have step-by-step approach, and sometimes we have to do uncomfortable things in the beginning to get to where we have to get. So that's my kind of.
So I want to stay with you there for a moment because one of the things we heard, we talked about implicit bias training and all those types of things. But I wanted to take a little different approach in terms of how we think about provider bias. And specifically, one of the things you pointed out was that I'm going to my notes. Physicians who experience burnout tend to show more implicit bias in their treatment of patients. Can you talk about that a little bit?
Yeah, I don't know where you got that. But I did say that in one of my conference. I did. I think she researched me very well.
The role of a good moderator is to do their
she
homework
did research
and make good
my
notes.
yeah. She did research my presentation. I had to give her credit for Shonta. I did say that it's actually a data-driven observation. Burnt out physicians are more biased implicitly. There's no question about it. because they lost their empathy, they lost their engagement, they lost their enthusiasm, what brought them into the profession. So there is a recipe for disaster, a physician burnout. So that's why the quadruple aim includes physician wellness as much as population health, as well as cost control, as the patient experience. We want the patient to have the best experience. But if the physician is not having a best experience, it's not going to happen. It's a dynamic, right? So both have to have a good experience in what they're doing, what they're achieving. So it is important. Physician burnout is issued, and that's one of my calling for this year, physician wellness program. Especially, even the medical students are experiencing burnout at an alarming rate. And my daughter is a second year psychiatry resident. I can sense a little bit of it in her, but I'm there to kind of guide her and give her hope. And being a leader, I can kind of make her a leader, because you have to lead. There's no other way. And medical students, the graduating, matriculating medical students are highly idealistic, highly motivated, want to go there and help and solve the problems and change the world, cure the cancer and whatever, and cure the mental health and all those things. But somewhere in the middle, they're getting more burnt out than their peers in the other professions. And then by the time they come out, they're even more. And during the residency training, it continues. In the early physician career, it continues. So it's a ticking time bomb, and we at least 200 physicians are committing suicide every year in this country alone. So that is almost like losing a class of medical students so, and we have physician shortage. It takes billions of dollars to replace these physicians who are burning out and turnover and all that. So physician wellness is very important for us to also take into equation when you're asking for quality and equity. And also a patient being treated by somebody who looks like them or acts like them, talks like them, is very important to avoid burnout too. And this morning I was commenting, everybody there has an accent, right? We have, all the speakers have accents, and we have to accentuate that accent. We are different, but that's what makes us unique, and that's what makes us uniquely connect with our patients too. So our accent should be accentuated, not be suppressed, and we should kind of use that as a tool to connect and bring diversity and bring inclusion and equity into the equation. So that's.
So as we think about what are those opportunities in our governance structure to really be strategic around how we embed principles and strategies that address equity in that. The other part is don't start from scratch, because the board of director, I'm going to get the title right, the board of directors health equity playbook is a facilitation guide, a blueprint of how you can actually take these strategies and embed them in your governance structure, right? I'm a quick read, I'm a quick study.
You do a lot of excellent research.
You did.
So don't reinvent the wheel. We spend so much time reinventing the wheel thinking that we got a new idea. It's not a new idea, it's just a new opportunity. And so there's a new resource out there to look at how you can embed these strategies in your governance structure. Be intentional about that integration, because in that intentionality breeds sustainability. It no longer is a checkbox, it's not longer just for this period, but really becomes embedded in the structure of your organization. And also, don't forget the importance of addressing burnout, because it has a potential, and not just physicians, but also nurses and other healthcare practitioners in the health system. This burnout can play out as a very unpleasant experience for the patients that are coming through your doors, whether intentional or not. So really thinking differently about what burnout looks like, how you address it, and how do you embed addressing these things in your equity philosophy for your actual organization. That also means, like I keep saying, we got to do some changing. So Tamika gave me this question. So outside of racial equity, when we start to think about things differently, highlight gender equity. For example, what deliberate approaches should health systems be considering when a transgender man presents in an emergency room for pregnancy care? That's y'all dessert. That's like heavy. You got to sit with that for a minute, right?
I mean, but when you think about it, it's very simple. This person was assigned female at birth. They live their lives as a transgender man. They still have the reproductive organs of a person assigned female at birth. They are deciding to start a family and they're showing up for care. And they walk into the emergency room with a full blown beard, button down plaid shirt and jeans with a bit of a belly and saying, "Hey, I think something's wrong with the baby." And what kind of looks are they getting? What kind of responses are they getting? Is someone moving as quickly as they would if the person had presented as, a woman or a female? What we're talking about here is first of all emotional intelligence, you know, and we're living in this world now where people have options and they're taking them, and we have to be prepared to be there and receive them and care for them in the same ways that we would anybody else. So we're looking at our intake procedures, the verbiage on our intake forms, the options that they have, the boxes that they have to check. Have we put all the boxes there possible? Should we take all the boxes away and let them write it in? How can we be more inclusive? How can we set ourselves up to be an environment where when they come through our doors, we know that regardless of their lived experience, they will be treated with compassion and care and dignity, and they'll get what they need to be better because that's why they've come. They haven't come to be further marginalized. And a lot of times that's what happens through a simple intake form. You know, preferred pronouns is just the tip of the iceberg when you think about all the different intersections. And Sister Love really, really works in those intersectionalities. And so we'll easily say, we're in the business of women, our work is women focused. However, when you think about a woman, she brings you her children, she brings you her partners, she brings you her neighbors, her coworkers, her friends. And so our theory is that if we center the woman, then she's going to bring us the entire community. And we have to be prepared to receive each and every one of them. And it means constant tweaking of our processes. Just when we think we figured it out, we got to start again because here's a new circumstance and we didn't consider this at first. So it needs to be malleable, it needs to be flexible and ready for what's next because the evolution will continue to happen over the continuum if we're committed to really, really showing up in the community and meeting people where they are.
So the question is, are our processes reflective of the community that we actually serve, or are they reflective of the community, a patient community that we desire to serve? Tweet that. Because I say that because oftentimes, right? But whereas if we go back to our conversation earlier, if your patient advisory board or whatever you have in your health system is reflective of representatives in the communities that you serve, then your check boxes, your intake forms, your processes, your governance structure, the patient encounter experience should be reflective because now you've not only given that person a seat at the table, but they influence the operation of the organization. So that's kind of a check and balance for us, huh?
We have a whole program that speaks to source leadership, and we believe that we, as service providers, as community-based organizations, as philanthropists, we show up in these communities with these grand solutions and ideas for what's going to make life better here for you all. But they weren't at the table when you were devising the plans. They weren't behind the scenes when you were drawing up the contracts or putting down the blueprints. They need to be there from start to finish, and not just in the room to hear your beautiful ideas, but there to influence and to guide them, giving them seats on boards, giving them positions in the offices that you're running, in the same way that banks are required to make a certain contribution in the communities that they set their brick and mortar buildings up in. Healthcare facilities should be required to partner with CBOs in their communities. They should be in the building. If I'm there from my CBO in the building at the hospital helping navigate, it makes all the difference in the world. And I get a job at my CBO, at the hospital. Like, everybody wins. The patient wins, the healthcare system wins, the CBO wins, the community wins. It only makes sense.
That goes back to Dr. Kolli's statement about everyone wins, right? Yeah. You too, John.
Yeah, the healthcare systems are powerful, right? I mean, everywhere there are monopolies almost, and they called what anchoring institutions nowadays, these universities and these healthcare systems. They have enormous power and influence and resources, and we need to make them accountable. With the great power comes great responsibility, right? We need to make sure that they adhere to that basic tenet, and they can be transformative. And I think some of them are doing it, but I think more needs to be done. And so we need to kind of encourage them and cajole them and guide them, push them, pull them wherever it takes, whatever it takes to make that happen. Because the individual physicians or small organizations or advocacy groups can only do so much, but where the money is, where action is, right? So we need to kind of engage them and elevate their attitude to where to pay their dues and make their responsibilities taken seriously. So we need to do that. And like you said, they're not just to sign off, they need to design it, the program. So signing is okay, but designing is more important. So we need to engage them from the beginning. Then they'll feel ownership of it, and they feel like there is some teeth in the game. And then they'll feel like, okay, this is my program, it's not somebody else's program I'm just supporting. So they feel ownership, they feel acceptance, and they will kind of make it happen. They will not let it go down, they will let it go continue.
I think
John-
one of the key things, though, is what you said earlier when you said there are two experts in the room. And I think we have to be really candid. The health systems have not viewed it that way. And so until you, no, I'm not saying you die, but until, but until you fundamentally get systems to believe in that premise, everything else is a challenge because it's viewed as we're doing this because we have to, or we're doing this, but fundamentally they don't believe that it drives the business proposition. And I'll just give you one example. I got a call from someone in Congress who wanted to talk about doulas. My wife actually taught teenage women, so I thought I knew a little about it. I quickly ran to figure out more about doulas. I called up our CEO. I said, you know, this congresswoman says for purposes of maternal health, doulas are really important. John, let me get you in contact with our chief of women's health, and she'll explain to you, you know, how we approach this, which he did. Now, board member calls, CEO is going to actually get someone in there to talk. So a very capable person gets on, and she essentially says, we don't really see much of a need for doulas. In fact, Mr. Daniels, we think it's a little counterproductive. So now here I'm a board member. Here's the expert. Here's the CEO. I'm like, okay. I call the congresswoman up. I say, you know, I've raised the question. 3 months later, I'm on the line with an excellent person from Mass General and describes some of the research on doulas. And now I'm armed with real information. So now it's not about me calling him up. He was well intentioned or saying the congressman, you know, it was data and information. And that's why I think the more that you described earlier, tearing down the verticals and getting the information, that is what changes things. Because until you get that data, until you change that paradigm, the rest of it is nice talk, but you know, for me, I'm about action. I want to see change.
So, you know, if we build on that a little bit, right? Because people can say, oh, this is hard work. This is HARD work. Yes, it's HARD work, but it's also HEART work as well. So, but we know we have evidence that there are things that you can do to really address inequities in healthcare systems and in healthcare delivery. So, what are some of those promising practices, John? So, what have you seen? It's for all of you. So, what are some of those promising practices that you've seen that actually have worked?
Well, I think 2 or 3 things that I would say would be very relevant. I think integrating into the governance process people outside of the traditional board of directors. So I'll just give you an example.
Number one, your step by step guide.
We set up a DEI committee that reported directly to the board in our system, but we didn't just let it be the directors. we also went out and recruited 4 or 5 people from around the country who came from organizations similar to yours and others. That dialogue was very rich and very, very different. The other thing I think is that we hear a lot of talk about sort of creating the pipeline, as you were mentioning, Doc. I mean, there really is a need to keep sustaining and filling that pipeline. I would hope that community groups will put a little more pressure on anchor institutions. Not just for, I want you to have a table at my event, and I'm like, what do, I mean, I would rather see people come in and say, hey, you want to see a change in the trajectory of kids who are going to go on to be in the healthcare profession? Here's where you need to spend the money. Now, this is a controversial line of stuff. Every health system in the country that I see, every system I go to, I'm like, if I watch a sports program, and I'm a big sports program, it's like everyone in the background, some health system is a sponsor. So now I'm asking myself, maybe that's a rational business decision, but what about sponsorship of other organizations that would have even more of a dramatic impact on the market? So I'll probably get fired when I get back to Milwaukee, but I'm standing on that.
We're going to stand with you because we already decreed we were standing in solidarity, right? Dr. Kolli, same thing. Promising practices. What have you seen that works? What do we do different?
I think what we're doing is something we need to continue to do: bring people together for learning experiences and lived experiences, and learn from each other, and just not talk but find solutions. Every problem has embedded solutions, but we need to kind of bring it out and make it happen. And so the most important thing is being at the table, representing the voices of people who are not being represented, and being vocal about it, and being effective about it, and being persuasive about it. We need to have a narrative and data, like he said. Data will tell you what this is good information. But unless you are there, you're not going to be able to tell that story. For example, recently, South Asian heart disease bill was passed by the House, and it's going to go to the Senate. But nobody knows the South Asian heart disease risk. We are the South Asian, we know it, but rest of the population don't know about it. They may know it as just one more article they read, but we read 10 articles because we are the subjects of it, right? So we advocate for it. So we went many times. It's already passed in one Congress, but didn't go anywhere. So now it's passed in this Congress. Now it's going to go to Senate. Hopefully Biden will sign off. So it's a small step, but it'll bring some resources. So every problem has a solution, but the people who has that solution has to be at the table. So we need to make sure that happens. That's very important. So the voices have to be diverse, and the opinions have to be there, and they need to be articulated. We need to give them the tools how to articulate it. So this is not a one person I can do it. The whole team has to be there to be like a kind of play the playbook. You can't win the game just with one player, right? You have to have the whole playbook and coach and quarterback and everybody else, and the cheering section too. Everybody needs to be there.
And so I'm going to allow Tamika to answer, but also get those questions ready because after her response, we're coming to you.
So promising practices, having these conversations to start with, and it's not new. Everybody's talking about customer-centered service delivery and trauma-informed. So the talk is there. In terms of practical application, definitely there's room for growth there. But I'll just give you an example. So Sister Love has a society of women, 290 of them now, that have all been living with HIV for more than 20 years. They're not just living with HIV, though. They're out talking to people about prevention. They're talking to people about staying in care, taking care of themselves, self-care, self-love. So they're living their best lives, and they're preaching the gospel of life past this diagnosis, right? So we team up with Grady Infectious Disease Program because they have a long list of people that have fallen out of care. I want you to think about the impact of hearing from this group of women who have all been living this experience. They know the value of staying in care. They know the quality of life that one can achieve with being, achieving medication adherence. So And it's way different from the nurse or the clinical assistant calling to say, hey, you missed your appointment, you didn't fill your medication. It's a different approach, and the impact is different. So that partnership with the larger entities, the larger providers, service providers, and those small community-based organizations, I keep reiterating the necessity for that partnership. Community health workers, they're the new nurses, y'all. I mean, I'm not trying to be funny, but yes, community health workers is just absolutely the way.
Like, I might echo the same thing. We have peer mentors in mental health care, right? So that has to be much more kind of used as a kind of a coaching, motivating to people to stay in treatments. Peer mentorship is very important.
So, questions from the audience. Come on. Oh, oh. In the blue suit, did you turn around because you got a question? Right here. And there's one in the back. Let me take these off so I can see. So there's one in the back and one here. Thank you. Thank you for bringing up community health workers. I think that has been something that's been in the forefront for many, many years. I'm from California, and we barely discovered the model in our government, and now there is some reimbursement. But there is such difficulty in reimbursement and the type of reimbursement that we just say that we want to do this, but we don't actually set up the systems to do that. So it's really to be an action item. If we say we want to do something, then let's make it easy for people to do that. For example, federally qualified health centers, organizations who can build Medicare services, but we all are valuable and make a difference. But yet we don't set up the systems for that. Absolutely. So as we think about standing in solidarity, right? One of the things we know every state has is a community. The other thing it all has is human beings. And the other thing that we've learned is the value of that peer-to-peer relationship. Now, we've been talking about community health workers for years. There is an opportunity for us to stand in solidarity to make that a policy initiative that is reimbursable and think about the economic stimulus in our communities if we can begin to employ individuals. So when we start thinking about health outcomes, we know what is it? 80 to 90% of health takes place in the community. We know we're talking about communities that have been historically disinvested in. This is an opportunity to right that ship and invest in it by this type of economic commitment to the infrastructure in communities. That's a solidarity opportunity for us. That's a policy opportunity for us. And if we're all singing that song, either somebody's gonna have to turn the radio on or turn the radio off. But even if they turn the radio off, if we're still singing it in our communities, people are hearing it everywhere they go. That's an opportunity for solidarity. There's another question right there.
I just want to say, in response to what you said, right after COVID, they opened the gates up for a lot of different things that we had never had access to before. So it can be done. And it shouldn't take, a threat to the world for us to get to that place.
And we got to make sure it keeps staying open. But
Yeah.
right here.
My question is, I was hearing about the all talking about what the league do, and I'm wondering if there are other examples you can share about ways that further continue to uphold partnerships with healthcare and other entities.
So I want to say, anybody who wants a copy of the playbook, let me know, and I will make sure that you get a copy of the playbook.
That's action step number one, John. Told you.
That's action step number one. And the other thing, I think that the comment that you made relative to the power of stories. I mean, if you think about people who are great communicators, whether they're politicians, religious leaders, they have a way of creating a narrative that is that catches you. So a couple of weeks ago, we were down here with the Black directors, and one of the CEOs got up and he said, "Look, there just was a published article in one of the big time journals about maternal health of African American women." And he said the number of African American women who die because of this annually is X. He gave the number, and he said, and we can change and fix that. Well, I don't know how many people really read the journal, But then when he said, I want you to think about this, that means that every day you fill up a 737 with African American women and they die. And when you tell the story that way, they remember it. And so I love your comment that you were sharing about the 20-year survivor. I mean, those kinds of stories, they cross racial, cultural barriers, and they cause people to act. Yeah.
And so, to your question in terms of other ways to do that, through some work with the National Minority Equality Forum, ACS CAN, and the National Comprehensive Cancer Network, they released the Elevating Cancer Equity Report Card. And there are some very explicit recommendations in that document that outline how health systems should collaborate with community-based organizations if there is this desire or this need to address cancer equity. So it explicitly calls out the need to partner and even procure services of community-based organizations in your efforts to address cancer equity. But it's the Elevating Cancer Equity Report Card.
Yes, absolutely.
Absolutely.
I agree. I think there should be a chief community officer, just like chief equity officer, chief wellness officer, chief digital officer.
With a comparable salary.
Yes, beyond living wage. Last question back in green. Okay, last two. I'm sorry.
We talked about it earlier. We need the data to talk. We need easy access and easily integrated EHRs, and we're moving in that direction. But being able to collect that data and share it real time with the pertinent people involved is essential. So the technical piece of this has to be in play.
Dr. Kolli, if all of you respond, that can be like your final thought.
No, no, exactly. I mean, the problem is the physicians are given like 15 minutes to take care of everything, right? So we need the rest of the team to be there and not in person, but in an embedded way so that we can deliver the care and integrate all the data. So we need to make the data easy to kind of retrieve and easy to put in. And so we need systems in place. This cannot be solved by person. It's a systematic problem and structural problem. We only can have structural solutions.
Oh, the lawyer goes last.
Yes. The
Yeah.
social worker will the social worker will come after the lawyer. How about that?
No. Thank you all, and thank you for what you're doing, because it is really important. Because there are literally millions of people who are affected by the people who are here today, and the systems who are here. So I just personally want to encourage you to keep doing the work you're doing, and certainly just not accept the status quo, because it's gotta change, and that's going to take courage.
And I'll answer so this way. So, Patient Advocate Foundation, national nonprofit, and we focus on those non-clinical barriers to care. So we're looking at the impact of lack of insurance and transportation and cost of living and everything else that you can think of, right? Because, like I said, 80 to 90% of health takes place in the community. We have to start looking at the social determinants, or more specifically, the social need gaps that are caused by unaddressed social determinants, and start treating them like we treat vital signs when people come into a healthcare system. We have to begin to ask about the impact of these social needs on one's ability to be able to access care, but more importantly, adhere. You can't tell somebody on a chemotherapy regimen to eat healthy if they have to drive 40 miles to be able to get a carrot. But if we don't ask that question, understand the context of that question in the context of it in making treatment related decisions, then we have the potential to do more harm. And then we categorize that patient as being non adherent. Like I said to somebody, it's not that they're non adherent, they're hungry. But if you don't ask me if I'm hungry, it doesn't matter what treatment you give. So if we can begin to think about how we integrate and assess for social need gaps, and more importantly, work with community based organization in a procured environment to help address those identified needs, that has to be a part of our path forward. And I'll close with one last quote from Dr. Kolli. He probably know I knew this, but in order to make an omelet, you have to break an egg. So let's go out and break some eggs.